Hi, everyone. Thanks so much for joining us. My name is Dr. Amy Roberts. I'm a cardiovascular geneticist, and I'm really pleased to be helping to monitor this cardiac conversation about lifelong care for individuals with Williams syndrome. Just to give you a little bit of an overview, I'll be talking in general about Williams syndrome and how it can affect individuals. And then we have the pleasure of having one of our patients with Williams syndrome and his mom here to talk a little bit about their experience. We'll hear from Dr. Degen about cardiac management, Dr. Porras about interventions with cardiac cath, Dr. Baird with surgical interventions, and then we'll be here for you to answer any questions you have that you want to submit while we're talking. So my job is to give an overview, though I imagine if you're here on this webinar, you probably already know a lot about Williams syndrome, either because somebody in your family has it or you yourself have it. But I will talk about some of the things that we monitor children for, and then adolescents and adults. Understanding, though, that I think it's important to remember that while it can feel like a very overwhelming list of areas that potentially can be involved, no child has all of these issues. And then for a given area, some children have no complications at all. But we do like to monitor and make sure that we find things earlier rather than later. In their earliest years, the preschool years, there are developmental delays commonly recognized, and this is usually related to lower muscle tone and extra joint laxity or joint looseness. So learning to do things and coordinate to do things like roll or crawl or walk can take longer than average, though of course most children do those things. And then later on, cognitive learning challenges can come up. Intellectual disability is seen in about 3/4 of individuals. It's typically mild. And oftentimes children have particular challenges with visual spatial construction, but lots of strength in language. And I think it's recognizing that profile, really seeing where an individual child's strengths are and tailoring school interventions to answer those strengths are really the ways to most effectively address and effectively educate children. There are some neurobehavioral considerations like attention issues, sleep issues, sometimes issues with anxiety that we also take into consideration. Obviously, all those things can also impact quality of life and school and things like that. You're going to hear in much more detail some of the cardiac complications of Williams syndrome, but the blood vessels or the arteries are often narrowed, and that's something that we monitor and decide when or if intervention is required. Some children have issues with the alignment of their eyes, some with the clarity of their vision that usually can be corrected with glasses, sometimes requiring surgery. Some children can have issues with hearing, either it's being hypersensitive to sound, which is called hyperacusis, and often gets better with age, or repeated problems with ear infections, sometimes requiring ear tubes. Many children do have some degree of hearing loss, and this actually becomes more common in adulthood, so we do want to continue to monitor hearing. In the GI system, a lot of early on feeding issues for babies. Chronic constipation is quite common, and so we want to treat that relatively proactively to avoid longer-term complications. There can be issues with calcium management, having high calcium in the blood or in the urine that can then be deposited and cause issues with the kidneys, so we monitor for those things as well. Some children can have short stature, shorter than we might expect based on the height of their parents. Some children have early puberty, which can be managed by an endocrinologist. So that's just a very broad strokes from 10,000 feet overview of some of the more common complications. But again, no child has all of those issues, and it's always better to find things earlier rather than later when they're smaller issues so that we can help children stay as healthy as possible and reach their full developmental potential. We have a multidisciplinary clinic, which is a 3-day overview that really addresses a lot of these issues. It's very neurodevelopmentally focused. So children who come through the clinic see physical therapy, occupational therapy, and speech therapy. They have a medical review with me, a cardiac review if they would like a second opinion on their cardiac management. They have a hearing test, visit with a speech and language specialist, have neuropsychological testing, and meet with one of our behavioral psychologists. These are all team members who've been taking care of children with Williams syndrome for many years. So that's our integrated care program. And then one quick word about, I was asked to explain the genetic underpinnings of Williams syndrome. Williams syndrome is due to a missing piece of chromosome 7. You can think of the chromosome like a file box that holds a number of files, with each file being a gene. So with Williams syndrome, one small piece of chromosome number 7 is missing, and there are a number of genes in that file box that are important for heart development and brain development. One of the most important genes is elastin, which is important for our connective tissue elasticity and is very important for the integrity of the walls of the arteries. And that's one reason why we have these arterial complications with Williams syndrome. Most people with Williams syndrome did not inherit it from mom or dad. It happened for the first time when the egg and sperm came together. There's nothing that a parent did prior to or during a pregnancy that caused it to happen. It's an out of the blue phenomenon. We all have changes in our genetic information. And this is one that happens to pop up recurrently in the population. So those are, sort of the highlights of the diagnosis. We can certainly dive into more detail if people have specific questions. But I did want to move on and have the real pleasure of having one of my patients, Daniel Wexler, join us along with his mom, Mickey Fox. Daniel's been a part of our children's program since he was 4, which is hard for me to believe. It makes me feel old, frankly. But we're so pleased to have you. Thanks for spending some time with us. Daniel is going to talk about some advice he has for children and adults who are living with Williams syndrome. Do you want to talk a little bit about that, Daniel?
Yeah. So I was born with Williams syndrome, and needless to say, definitely it's definitely like hard sometimes because, like, I'm not perfect, and I do frankly make mistakes, and um it that's what all of us do, but like again, I don't try to do them, but it does happen like once in a while. So my advice would be to, like, I would I would say just, try, like, try and not make mistakes, but then try to fix them. Um, because I can fix some things, but um, for example, like if I forgot to, like, do something and my mom has told me I mean, then it's on me because I forgot, but um, my mom would like sometimes repeat once or twice. It happens, but I would say for the people who have wounds kids is um important to, like, know your mistakes and then don't do them again. Um and try to move on from them. Um I I I am a very nice example of, like, um of fixing them. I'm also like a very nice uh person. I think I think for me going to going wasn't to was really helped me a lot. Um like like I saw like a lot of people, um like the people on here, and I really love the support because um even though Button Children's Hospital is far, it's still like I still like going there because it's really helpful. I also give advice to, like, find a hospital that can help you, like, with your problems. Because Miss Amy has, like, really helped me. Especially when I see her. It's
Known you since you were very little. It sounds like,
like,
Daniel, it sounds like what you're saying is your advice for people with Williams syndrome is to sort of give yourself a break, make mistakes, but you'll
yeah,
move on. And then maybe some advice for parents is to be patient with your child with Williams syndrome, right?
Yeah,
Because some
like
mistakes happen.
I mean, yes, like um yeah, it's really often, like I said, it's really often. Like I don't do them all the time, but it's like super, super often. Like
We all do. We all need reminders, which is
yeah.
why it's good that to have your mom, because I know she's been
But
super helpful too, right?
anyways, the bottom line is that um the people on here who have syndrome, or the kids rather have syndrome, is that like please give them a couple minutes to figure your mistakes out, and then you can like tell them what you did wrong or something.
Help them figure out a different way, maybe.
Yeah, instead of like screaming at them, or like, you know,
I'm
um
sure your mother's screaming at you, Daniel.
uh I she has, but like she hasn't done
Believe.
she has not done like
Should
out like all the time.
Yeah, no, of course not. Daniel, should we let your mom also chime in? We wanted to ask
Yeah.
her what her experience has been with having you and then working with the team at Children's.
Yes. Actually, we went to the children's hospital for the first time when Daniel was 4 years old, which is 15 years ago. Yeah, he was diagnosed in Japan. So from the birth to 4 years old, we were in Japan, and then there was no hospital like Children's Hospital Boston, like people who knows about Williams syndrome so well. So I felt like I was in the dark. I was walking like in the dark. I didn't know what to do. And I was just searching information on the internet. And then really there was no information. But as soon as we came to the United States and then reached out to the Boston Children's Hospital, we found out the probably best hospital in the world is there close by.
Yeah.
For seniors, we're very lucky that we were able to.
It's like so amazing. Like
Yeah.
like I was saying, it's really like the best hospital ever. Because
Yes.
I have my wisdom teeth taken out there, and they were like so supportive. And they were really helpful. But my mom's definitely right. I mean, I love coming there.
Yes, and then he's luckily physically very healthy, so he hasn't have any cardiac issue. Um, but he used to be go to the Williams syndrome clinic every year. Since he got older, and so every other year right now. But we did checkup every year. And it was very helpful that even though he didn't have health issues, we were able to see all other doctors and behavioral doctors, psychologists, all other people, and then it has been very, very helpful. And then basically overall, I had a toughest time from birth when Daniel was born to 2 years old. I didn't remember when I slept. During that time, I couldn't sleep. Daniel used to cry 5 hours straight in the night, and then he screamed. He screamed for hours and hours. And then, so I was like a zombie for 2 years. But at 2 years old, he started to walk, and then things started to change. He got better. And then we came to the United States, and then he joined pre-K, and then he just finished the 12th
Yeah,
grade.
I graduated last year.
Yeah. So those school years, he had a very good life. I was happy. He was happy. Overall, it was very good. But I feel like we are heading to the second challenging time right now. I feel like we are going to the unknown stage, like after school age. What he's gonna be like? I'm getting older, and it's a different issues in my mind. It's a different than when he was younger right now. So I'm kind of a little bit struggling right now, but Daniel and I just attended the Williams syndrome convention in Buffalo, New York, and we met so many people. There were 800 attendants right there, and we've seen a lot of people with Williams, from the baby to elderly people. We learned everybody's so different. Like some people seem to have health issues visibly. Some people that not, like Daniel. It's some people were doing volunteer. Like I didn't even see he had a disability. It's a very wide range that intellectually and physically on both level. Yeah, that's what I feel. But I did I answer your question?
Absolutely did. Absolutely did. It actually was a full segue, because I think you sort of put your finger on one of the areas, or the one of the aspects, which is just that no two children are alike. And so how do we address, well, we know our potential issues, but tailor them to the individual presentation of a child. So we're going to transition. Thank you so much. Thank you, Mickey. Thank you, Danielle. So great to hear.
And one more thing that I want to mention. We went to so many hospitals and see doctors and nurses, but the staff in the Boston Children's Hospitals are at the best. They are very professional, very nice, very thoughtful, and I've never seen a hospital like that. So I'm very we are very lucky that we've been patient of the Children's Hospital. So thank you so much for all you do. We appreciate it so much.
Thank you. That was very kind. Thanks, Nikki. Great. I am going to transition to Dr. Degen, one of our cardiologists. We've got some questions. We're going to start there, and then, of course, if other questions come up, people can add them to the chat. But the first question for you is, which heart conditions are associated with Williams syndrome?
Yeah, thanks so much. It's such a pleasure to be here, and so nice to hear from Mickey and Daniel. Thank you. So by and far, the most common associated heart defect with Williams syndrome is supravalvular aortic stenosis. So the aorta is the big blood vessel that comes off of the left side of the heart and is responsible for supplying the oxygenated blood to the body. And above that area, there can be narrowing. That's the most common in the whole arch, actually. So the aortic arch the whole thing can also be narrow. And the other types of heart disease that are common is pulmonary artery stenosis, particularly in the branch pulmonary arteries, and including in the small segmental branches in the lungs. And Williams syndrome is interesting in that it's one of the genetic defects that can affect both sides of the heart, which is a little bit unusual. And then in terms of other problems with the heart, there can be abnormalities of the relaxation of the heart or repolarization abnormalities. So the QTC on EKG can be abnormally long. There can be problems with the coronary arteries, which are the small arteries that also come off the aorta. and supply oxygenated blood to the muscle tissue of the heart. As secondary issues, the heart can also develop thickness because there's obstruction of blood flow out of the heart, either on the left or right side or both. And lastly, we also know that patients with Williams syndrome are at increased risk for development of hypertension. So those are the primary things that can be going on with the heart.
Great. At what age are these heart conditions typically identified?
The most common way I get a diagnosis for somebody with Williams syndrome is typically in infancy. They're referred for a murmur, and we see that there is heart disease that can be consistent with Williams syndrome, meaning both the left and the right are affected, or something that seems otherwise consistent with Williams syndrome. Or patients have a diagnosis of Williams syndrome for other reasons, genetic diagnosis, and then they come see me to evaluate the heart. So it can be one of either way, but oftentimes the diagnosis is made sometime during early childhood. And I'm often evaluating patients if it's the first time they're seeing a cardiologist, usually between 0 to 3 years old.
Not everybody lives in a place that's close to an expert cardiologist like you. What do you think is a good guide for families? When should they seek out that extra specialized support from a cardiologist who knows more than average, I guess I would say, about Williams?
Typically, if the disease is on the more severe end of the spectrum and surgery or interventions are being considered, it can be helpful to have another opinion or to just have another evaluation, because of course there's a huge variety from very mild to almost no heart disease or no heart disease really, up to a severe heart disease that affects both sides of the heart and causes issues early on. And so in the situation in which the disease is pretty complex, I think it would be appropriate to have some evaluation by a Williams specialist.
How often do kids need interventions or surgeries?
Yeah, there is a bias a little bit in the literature because the patients that ended up getting interventions tend to be the ones reported on. And so, there's probably a bias about the more severe cases, but probably it's actually a minority of patients who end up needing an intervention, maybe somewhere around 20 to 30%.
And for those that are more mild, how often do you see them, and what are your recommendations? How does that change as people get older?
Certainly in the first part of, so between the ages of 0 to 1 is the most common time to see changes in the heart disease. So typically for patients that I follow with Williams syndrome who are less than a year, I see them at least every 3 months or so, especially if there's any involvement. And then beyond that, about once a year between the ages of 0 to 5, and then beyond 5, about once a year, once every couple years. Although it can really vary depending on the specifics of the patient. Certainly there are patients who I need to see more frequently, or certain patients that I don't need to see quite as often.
Yeah. So I think, probably true for everything. There are guidelines, but then we personalize things. Don't just treat people that's, fitting into guidelines for
exactly
consideration. Yes. Great. Okay. I'm going to ask some questions I have some questions for Dr. Porras and Dr. Baird. Dr. Porras is one of our interventional cardiologists who does a lot of the cardiac cath, and Dr. Baird is one of our cardiac surgeons. So Dr. Porras, can you walk us through how you evaluate patients and determine if a cath or surgery or both is needed?
Yeah, sure. Luckily, as has been said, it's only the minority that need those things. But by the time we get involved, usually there's a lot of data already because people have been following the patient and considering this. So typically we'll have an echocardiogram for sure. And so we'll review that very carefully. And a lot of times we also have axial imaging, meaning with a CT for the most part. And so if we have that, then we'll review that as well. And we'll sit together with Dr. Baird and Dr. Degen and review everything together once we have all the information and try to make decisions as a team, just considering the anatomy, but more importantly, how the patient's doing and all the details of their history. So overall, we try to take a less is more approach. Like, we want to do the minimally invasive thing if that's the right thing, but more importantly, we want to do what gives us the best result long term, even if that's surgery. And for Williams, because the parts that are commonly involved are more amenable to surgery, that's kind of where we tend to end up. But it's a big spectrum, so you might have patients that don't really have those things and have other things, so you might treat them in the lab as well. But even whenever we're considering surgery or an intervention, we'll do a cath, and especially for the cases where we're kind of not sure, because the cath will give us very detailed information about the anatomy, but also about the pressures in the heart and how the heart is handling all of this. And it gives us a very good look at all the parts that we worry about that would require surgery. So it's important for us to make sure that what we're proposing is necessary. And in some of those cases, the diagnostic cath will become a therapeutic cath. What we find is that maybe the lesions are not enough to warrant surgery, but we can fix some of them in the cath lab and things like that. But I think over time, we've learned a lot about what is better for each situation. And so we're trying to kind of incorporate all that experience and learn from our past experience as well. And we'll make recommendations based on all of that.
What exactly are you doing in the cath lab when you're intervening? What do you see that looks like, oh, I think I could help with that? And then what are you actually doing?
Yeah, so just to take a step back, a catheter is just basically a long tube that you insert through usually from the vein and artery coming from the leg, and then you navigate that using X-rays to see where you are and get all that information. And so it's a very kind of well-established tool for diagnosis, but as well over the last 30, 40 years, it's become a therapeutic field as well, through the same types of catheters, just more specialized, maybe bigger if you're going to do an intervention and things like that. So it's a bit the same procedure as a diagnostic. The way we prepare for it and all of that is the same. The lesions that you would treat in the cath lab are if you find that surgery is not needed and there's discrete lesions in different places, that's the kind of thing we're looking for. In Williams, because it's the vessels themselves are kind of diffusely abnormal, it's rare to have those little discrete things, discrete lesions like that. It tends to affect the vessel in its entirety, or at least for longer segments. So those are the kinds of things we're looking at. There's also, for example, if we wanted to delay surgery because it'll be safer when the patient's older, then we were able to temporize things and get things a little bit better in the cath lab. And also, if it's an area that is difficult for the surgeon to reach, we might treat that in the cath lab as well. It's a little easier for us to reach certain places, and obviously less invasive. So all of those things are kind of being considered at the same time.
Dr. Baird, do you want to talk about some of the more common procedures that you do, and when you're deciding that it's time to actually intervene surgically?
Yeah, sure. So we've had an interest here in Williams syndrome, at least surgically, for many years. And surgery first evolved for Williams syndrome. I think, as was mentioned, one of the more common presentations is supravalvular aortic stenosis. And many people are familiar with the fact that area needs patched. And historically, long ago, it started with one patch, evolved to 2 patches, and then 3 patches. So I think that is kind of the most common reason that people are frequently referred to surgery. However, when a referral comes for surgery, there are essentially 6 areas that I think are really critical that need to be looked at and really understood. And I agree with Dr. Porras, is less is more until surgery, and then more is more. The reason I say that is because in Williams in particular, if you operate on several lesions but leave a lesion or two, and I'll go through those, then you could be set up for failure. And I think this is one of the most common mistakes that centers make when not addressing all of the lesions that need to be addressed. And I think that is, to me, one of the most important things that Dr. Porras and the cath lab and the imagers can help us do preoperatively, really understand the details. And those 6 areas are the supravalvular area, just above the valve, the coronary, usually the left coronary area, just in the same area, the ascending and then descending aorta, and then over on the right side, the pulmonary arteries, and then finally under the pulmonary valve and the right ventricular outflow tract. And if each of those areas need to be really assessed and understood, and when we go to surgery, if we're going to address the supravalvular area, very frequently we need to address one, potentially all of those areas. Now, having said that, we often work in combination with our catheterization doctors, and we try to coordinate the efforts. In other words, because it's somewhat of a lifelong disease, particularly when you start to develop obstruction, say in the pulmonary artery side, frequently we'll go back and forth and have the discussion of, should we address this now, or can you address this in the cath lab, and we defer, and then the cardiologist will continue to manage those lesions and help manage that. So I think fundamentally from a surgical standpoint, there are common lesions that we address, the supravalvular aortic area and the pulmonary arteries, but really importantly are the other 4 or 5 areas that we critically look at the same time we're doing surgery on those areas.
You mentioned it's problematic to do some, but not all. What happens when you do that?
So I'll give a really good example that I've talked to other surgeons in various parts of the world, and they've operated on a Williams child and they have trouble after surgery. And the most common reason I found is, for example, doing the supravalvular aortic area, but not addressing the left main coronary. So probably 15 or so years ago, we really focused on that and took that on. And we probably operated on a dozen or so of those patients, and we addressed the left coronary, we fixed it, and then we actually published that, and that's in the literature now, very specifically addressing that. So the point is, that's one of the lesions in particular we like to look at. It doesn't always need to be addressed, but we look at it carefully, and if it needs to, then you need to address it. The other are, for example, the right ventricular outflow tract. Sometimes that's a very thick muscle, and we can address all the other lesions, and if we leave that really thick muscle, then blood can't get out of the heart, and the catheterization doctors really have a hard time addressing that. So I think all of these areas, we like to have a discussion and get the imaging and the catheterization results to really help define, to answer the question you're talking about. But those are a couple of the more common ones. And then another one that we frequently address, and I'll go back to Dr. Porras on this, is that a lot of times when you address the supravalvular area and maybe the ascending aorta, and the patients go home and start to come back because now the transverse arch in the descending aorta becomes a problem. And so they go back to the catheterization lab, and maybe, Diego, you can discuss a little bit about this and what you guys have to do and how it becomes a little bit of a lifelong management, and then sometimes how they have to come back to surgery.
Yeah, this goes back to what I was saying before, that we've learned a lot over the last 20 years, and we're trying to incorporate all that into our practice. When you have narrowing of the aorta, you can definitely, we've definitely dealt with that in the cath lab, either with balloon dilation or placing stents. What we learned over time is the result right away is very good, but the issue is that these vessels respond to what we do to them as well, and the response can lead to more narrowing. And so it's the kind of thing where you do an intervention, looks good, and then a year later, you're back. We've also seen issues with, especially with stents, like if, let's say the lesion is this long and then you put a stent there, it looks great. Then you start to get narrowing at where the stent ends. And in the past, we would go back and say, okay, well, add another stent, and then you end up with like a chain of stents after a few years, and you keep having that issue, or also something called in-stent stenosis, which is a narrowing inside the stent, just from the vessel reacting to that stent. And so in those situations, now, I mean, if it's a very discrete lesion, we might try that. If it's these long segment narrowings, we will consider surgery, even though it's way more invasive, trying to figure out how to prevent this problem from happening, where we're just kind of chasing our tail there. And what Dr. Baird has done and makes a lot of sense to me is he'll patch that open. So you're replacing part of the wall with a patch. And so you won't have that response of circumferential narrowing. And I think that's why they've done better. But these are things that we've learned over time, and it just comes with a lot of experience and seeing what happens. And it's very particular for Williams specifically. So that's where it comes, like, it's very valuable to be at a center that has that experience and have different tools to deal with that problem.
Yeah. Dr. Porras, Dr. Baird, do you want to address the very specific, albeit not that common, issue of Midaortic syndrome?
Yeah, I can talk about that a bit. Thankfully, that's not very common in Williams, but it's if you look, Midaortic syndrome is basically narrowing of the aorta after the arch. So meaning in the abdomen usually, or in the thorax, but after the arch. It can also involve vessels that, just like we talked about, the supra AS can involve the coronaries. The Midaortic syndrome can involve the vessels going to your gut and especially to your kidneys. If you have narrowing of the vessels going to your kidneys, then the response, the normal response for your body, is to generate a lot of hypertension. So that's sometimes what we see. It's patients that have a lot of hypertension that is difficult to treat, and we look at the arch and everything looks good. But then when we look down in the abdomen, we start to see those things. For the majority of patients, it's pretty mild and it doesn't require intervention. It's just something we follow. But once in a while, you'll see pretty significant narrowing, and that requires yet another team to get involved, because it will require vascular surgeons and cardiac surgeons, sometimes one or the other, but it can be more extensive and more difficult to manage. But thankfully, that's pretty rare for Williams. In the majority of patients, when we see it, it's mild and it stays like that, so we just follow it. But it's something to keep in mind.
Yeah, as Dr. Porras mentioned, when it comes to surgery, there's another whole set of expertise, including the abdominal surgeons that have a real interest and expertise on helping us from the cardiac surgery standpoint manage that. So I think, if you have Midaortic syndrome, I think there's really an excellent opportunity to be evaluated from that multidisciplinary group to really help define whether an intervention, surgical or non-surgical, would be best for you.
That's helpful. Thank you. Dr. Degen, do you want to talk about the special anesthesia considerations, maybe not just in the context of cardiac interventions, but also in general for children and others, older people with Williams?
Yeah, certainly we know that patients with Williams syndrome are at increased risk during sedation and anesthesia. The risk is highest with cardiovascular procedures. And also we think, when you have narrowing at that supravalvular aortic region, especially because there's probably interaction, as has been mentioned already, with one of the aortic leaflets in the left coronary. I think those are the highest risk situations, but certainly there is increased risk overall. So generally what we recommend is that the anesthesiologist are familiar with caring for patients with Williams syndrome, and that if possible, to try to coordinate procedures that would require sedation simultaneously, if at all possible.
I think another comment, from a surgical standpoint, and any advice that we can give is that when these patients go particularly for interventions like cardiac catheterizations, wherever you are, just make sure the institution is well aware and informed of these potentials, because they're real. And here, if there's any question, the catheterization doctors will alert surgery and alert us to be immediately available for any necessary acute procedures. Because if there is interaction with any catheters or with the induction of anesthesia, there are cardiac arrests that have been reported and do occur. So we take that very, very seriously. And so the team here will do a full evaluation if you're getting any procedure. And that's why a little bit about what Daniel was talking about in terms of being able to help be managed by Children's Hospital. The cardiologist, including Dr. Roberts and Degen and others, and anesthesiologists will help make the determination if it's safe for those other procedures, or do we need to have some potential interventions. So I know you guys think about that a lot, Amy and Michelle, as you're seeing patients and considering whether other procedures should occur non-cardiac.
Right. Yeah, it's a question that comes up a lot. And I know, Michelle, you answered that question quite a bit. Along those lines are lots of questions about QTc prolongation and those considerations with medication. How do you advise?
Yeah, usually, every medication comes with a risk and benefit. So we weigh those risks and benefits. And we also look at the baseline QT. And then I often will, if the medication is known to cause QT prolongation, getting a ECG after starting that is totally reasonable, because we know patients with Williams syndrome have overall higher QTc than patients without. So.
And what does that mean? What does it mean if it's prolonged? What is the problem with that?
Yeah, basically like with relaxation of the heart, which can predispose to increased risk of arrhythmia. And so that is one of the reasons why, if you're starting medications, or there's lots of, certainly if there are several medications that are QT prolonging, it'd be helpful to have an ECG afterwards.
I wondered, Dr. Porras, if you could talk a little bit about, I know, if you have a 1-year-old who's not had vascular issues, if you have a 5-year-old who's not yet had vascular issues, if you have a 10 or, how does it change? Just, do you see that some individuals seem to be much more prone to it and others are immune, or do you see later presentations?
Yeah, no, usually Williams syndrome is very interesting in a lot of ways, but one of them is most of the time we'll see it in infancy, and that's where it changes pretty quickly. But on the right side of the heart, so the pulmonary arteries, we can see it change for the better too. So a lot of times if it's only right-sided disease and we have the luxury that the right ventricle is working well and the pressures are not super high, we'll wait because we've seen it get better on its own. And so that's pretty unique for the usual things that we see. On the left side, I don't know of cases where it got better on its own, so it's probably a more static thing. But when we see the changes is when they're going through growth, and the first year of life is a major growth spurt there, like the double, triple their size. So that's usually where we see it. Later on, it's rare to see it advance, but for sure it can happen for sure. Because part of it is the abnormality of the vessel, which is a fixed thing, but it's also that the vessel is reacting as well, and that response to different flow dynamics and things like that can lead to more narrowing. And so that's why the follow-up is so important. So if we see somebody at 10 with a little bit of narrowing of one of the renal arteries, maybe an aorta that looks a little small, we'll still re-image later on and keep an eye on the blood pressure and everything, because it can advance as well. The majority of patients, it stays pretty static, thankfully, but yeah, that can happen. So the follow-up is really key.
All right. Any other points that anybody else wanted to make? I think we've addressed the questions that have popped up so far in the chat, but also happy to answer if people want to enter more, or if anybody here who's on the panel has anything that they wanted to add. Now would be a great time to do that.
I think the bottom line is if you're a patient or you're a family member and you have an interest or really would like us to evaluate or consider what might be best for you, any of us would be happy to do that from whatever level it is. If you're really don't have cardiac disease and just want to be followed from a cardiology standpoint or have second opinions about catheterization or surgery, please reach out and we'll be happy to try to provide the best opinion we can.
Other thoughts? All right. Well, thanks so much for joining us. This is our contact information. If you're interested in learning more, please don't hesitate to reach out. We field questions all the time and are used to answering either one very specific question or more general questions, arranging for visits if that's what you're interested in. So please don't hesitate. It's been a pleasure to be able to share a little bit of what we do. This is one of my very favorite patient populations. Working with kids with Williams syndrome is as rewarding for us, I think, as it is helpful for the families that come here. So it's really our honor. So thanks so much. I hope everybody has a good night.